Welcome to Ink and Air, your audio resource for anesthesia insights, and we're brought to you by OptimalAnesthesia.com.
Great to be here.
And just a heads up for everyone listening, we're really excited that detailed, evidence-based explanations for the topics we cover, including today's deep dive, they'll be up on OptimalAnesthesia.com starting around June 2025.
Yeah, we're aiming to provide that extra layer, for digging even deeper into the evidence behind these practices.
Absolutely. So today we're jumping into a really interesting real-world case. Anesthesia for repairing a CSF leak that's cerebrospinal fluid rhinorrhea, specifically an endoscopic repair right at the cribriform plate.
It's a really fascinating intersection, isn't it? Sort of ENT meets neurosurgery anesthesia.
Exactly. And if you're interested in those areas, this is definitely relevant. We'll also have visuals, diagrams, and all the references for this discussion up on OptimalAnesthesia.com when that section launches.
Good stuff. And it's one of those cases that, well, it looks straightforward maybe on the surface, but the anesthetic considerations, they really stack up when you look closer.
That's the perfect way to put it. So let's paint the picture. We've got a 37-year-old woman. She comes in with spontaneous CSF rhinorrhea. Imaging, a CT cystoscopy, shows a 7 by 2.5 millimeter defect right at the cribriform plate.
Right.
History-wise, there's a road traffic accident, but it was remote, like 17 years ago. And one little detail, seemingly minor, but we'll get into why it matters. She has dark red nail polish on. She's heading for endoscopic skull-base surgery to fix this leak.
Right.
So, immediately, thinking as the anesthesia provider walking into this, what are your first thoughts? What are the absolute non-negotiable anesthetic factors you have to consider? How are you thinking about induction, maintenance, and, like you said, what makes this maybe more complex than it first appears?
Those are exactly the questions, aren't they? And to tackle them systematically, let's use a framework. Let's think why this case matters anesthetically, how we actually approach managing it, and then what are the key takeaways, the things you really need to remember.
Okay, sounds like a plan. Let's start with the WHY. Why is this specific scenario, CSF leak, cribriform plate, endoscopic repair, why is it so significant from our perspective?
Well, the core issue with CSF rhinorrhea is that you've got a direct line, basically, a communication between the subarachnoid space, which is supposed to be sterile, inside the head, and the nasal cavity, which isn't sterile.
Right. Big infection risk there.
Huge risk. Ascending meningitis is the major concern. It's a really serious, potentially life-threatening neurological infection.
So meningitis is top of mind. Yeah. And the location, the cribriform plate itself, that adds complexity too, right?
It really does. The cribriform plate is, well, it's incredibly delicate. It's thin bone right there near the olfactory nerves for sense of smell and just underneath the frontal lobes of the brain.
So prime real estate, neurologically speaking.
Exactly. A defect there doesn't just risk meningitis. You're also worried about things like air getting into the head, that's air embolism or pneumocephalus, and other intracranial infections too. Its proximity to everything vital just dials up the stakes for anesthetic management.
You also mentioned earlier, or it's often mentioned, a link between these spontaneous leaks in women this age and maybe an underlying condition.
Yes, that's right. Particularly in middle-aged women, spontaneous leaks sometimes point towards idiopathic intracranial hypertension, or IIH. Now, it's not mentioned explicitly in this case summary, but IIH means elevated pressure inside the skull without an obvious cause, like a tumor.
So we need to consider that the patient might already have higher than normal intracranial pressure even before we start.
It's definitely something to keep in the back of your mind, absolutely. It could influence their baseline ICP and how they respond to anesthesia.
Okay, so considering the meningitis risk, the delicate location, potential IIH, what are our primary anesthetic worries here? What are we trying to prevent?
Our main goals revolve around stopping any rise in intracranial pressure and also preventing any increase in pressure within the nose, especially during positioning or, critically, when we're managing the airway.
Ah, right. Because things like coughing or straining.
Exactly. Coughing, bucking on the tube during intubation or emergence, even just positive pressure from the ventilator if it's not managed carefully. Any of that could potentially disrupt the surgeon's very delicate repair work.
We definitely don't want to undo their work. So given those concerns, what are the big picture anesthetic goals we're shooting for?
Okay, so we need, number one, optimal surgical conditions. That usually means aiming for a relatively bloodless field for the surgeon. We need stable hemodynamics, blood pressure, heart rate throughout. And maybe most importantly, we have to protect that surgical repair during the whole anesthetic, especially ensuring a really smooth, gentle wake-up.
That makes total sense. Okay, let's shift gears to the HIW. How do we actually approach this anesthetically? Where does the planning start?
It all starts preoperatively. You absolutely need to confirm there's no active infection, meningitis, or sinusitis, and assess for signs of significantly elevated ICP before you even begin. Then you need to carefully review that preoperative imaging, the CT cysternography.
That's the roadmap you mentioned.
Precisely. It shows the defect's location, its size. That information helps both the surgeon plan their approach and us plan our anesthetic. Things like positioning, maybe potential blood loss risks.
And what about that nail polish detail I mentioned? The dark red polish, that's actually relevant.
Oh, absolutely. It's not just cosmetic here. Dark nail polish, especially reds, blues, blacks, it can really interfere with pulse oximetry.
How so?
It absorbs the light wavelengths the pulse oximeter uses, so you can get falsely low SpO2 readings, which is obviously a problem, especially if you're maybe allowing a bit of hypotension for surgical field optimization, or if the patient gets vasoconstricted.
Okay, so what's the solution?
Have a low threshold to just use a different spot. The earlobe works well, or a forehead reflectance probe. Or, simplest of all, just ask the patient to remove the polish from at least one finger beforehand.
Good practical tip.
Oh.
Okay, moving on to induction. The case notes list a specific cocktail of drugs. Let's break down the why for each one. Glycopyrrolate, 0.2 milligrams.
Right, so glycopyrrolate is an anticholinergic. Here, it's mainly used as an anti-sialagogue. It dries up secretions in the mouth and airway, which is helpful for nasal surgery, makes airway management smoother. It also helps maintain heart rate, preventing bradycardia from other drugs or reflexes.
Okay, midazolam, 1 milligram.
That's for anxiolysis, reducing anxiety before surgery, and it provides some amnesia, too. Helps the patient relax.
Fentanyl, 100 milligram.
A potent opioid. Key role here is to blunt the airway reflexes during laryngoscopy and intubation. Less coughing, less straining means less potential for ICP spikes.
Makes sense. Propofol, 150 milligrams.
Standard 4 induction agent. Nice, smooth onset, fairly quick offset. Importantly for this case, propofol also tends to lower intracranial pressure, which is a bonus.
Good point. And finally, atracurium, 40 milligram.
That's our muscle relaxant, a neuromuscular blocker, essential for relaxing the jaw and vocal cords for a smooth intubation and preventing any patient movement during those critical initial surgical steps.
Okay, that clarifies the induction strategy. Then, airway secured with a size 7.0 endotracheal tube. Anything specific about the tube choice or the intubation technique itself here?
Size 7.0 is pretty standard for an adult female, a good balance. The real emphasis, though, is on the technique. It needs to be smooth, gentle, atraumatic. Any excessive force, any gagging or coughing during laryngoscopy can bump up that ICP. So finesse is key.
Got it. Smoothness is the goal. Okay, we're induced, intubated. Now, maintenance. The notes mention balanced inhalational gas or TV total intravenous anesthesia as options.
Yeah.
Is one better than the other here?
Honestly, both are perfectly reasonable choices. Inhalational agents like sevoflurane or desflurane give reliable depth control. Teva, usually with propofol and remifentanil infusions, allows for really fine-tuned titration and might offer maybe some theoretical ICP benefits, plus potentially a faster, clearer emergence. The choice often comes down to provider preference and experience.
And regardless of which one, continued muscle relaxation seems important. Atracurium infusion at 10 millirater.
Yes, absolutely crucial. Continuous neuromuscular blockade ensures the patient remains perfectly still. Any sudden movement, a cough, anything like that during delicate skull base work could be disastrous. So maintaining relaxation is non-negotiable.
Okay. And then there's a whole list of other meds given during maintenance. Dexmedetomidine, magnesium, dexamethasone, paracetamol, diclofenac. That looks like a very deliberate multimodal approach.
It is. It's all about hitting the targets from different angles. Dexmedetomidine, 30 mics, that's an alpha-2 agonist. It adds sedation, some pain relief, and helps keep hemodynamics stable, often meaning you need less of the primary anesthetic agent.
Okay. Magnesium sulfate, 1 gram.
Magnesium has a few potential benefits. It's an NMDA receptor antagonist, which might help with pain control, potentially reducing opioid needs later. It might also contribute to smooth muscle relaxation, possibly helping with blood pressure control.
Dexamethasone, 8 milligram.
That's Dexona. It's a steroid, given mainly for its anti-inflammatory effect. Helps reduce swelling around the surgical site postoperatively.
And the last two, paracetamol IV and diclofenac suppository.
Pure multimodal analgesia. Paracetamol, acetaminophen, and diclofenac and NSAID work via different pain pathways. Giving them intraoperatively provides preemptive analgesia, gets pain control started early, and the goal is definitely to reduce the need for opioids after surgery.
Right, minimizing opioid side effects. Now, a really critical point mentioned is avoiding nitrous oxide. Why is that such a big deal in skull base cases?
Huge deal. Nitrous oxide is, well, it's much more soluble in blood than nitrogen, which is the main gas in air. If there's any trapped air inside the skull, which there could be from the defect itself, or introduced during surgery, nitrous will diffuse into that air pocket way faster than nitrogen can get out.
So the air pocket expands.
Exactly. It can significantly expand that pneumocephalus, potentially causing a dangerous rise in intracranial pressure, maybe even herniation, and it can compromise the repair. So nitrous is generally considered an absolute contraindication whenever there's a breach in the dura or potential for intracranial air.
Okay, definite take-home point there. No nitrous. What about ventilation during the case? What are the goals?
You generally want to aim for a normocapnia or perhaps mild hypocapnia. So keeping the end-tidal CO2 and ideally the arterial PaSO2 around 30 to 35 millimeters of mercury.
Lie slightly low.
Mild hypocapnia causes some cerebral vasoconstriction, which can decrease cerebral blood volume and therefore help lower or control ICP. You don't want to get too low, as that can risk cerebral ischemia, but keeping it in that low normal range is often beneficial. Also, avoid high ventilator pressures, high PEEP or high peak pressures, as that could theoretically force air through the defect. Gentle ventilation.
Gentle ventilation, slightly lower CO2.
Got it.
Okay, surgery's wrapping up. We're heading towards emergence. This sounds like maybe the most critical phase for protecting that repair.
Yeah.
The notes mention swapping the ETT for an iGel supraglottic airway. What's the thinking there?
Emergence is definitely high risk. You need the patient to wake up without any coughing, straining, bucking, all things that dramatically increase ICP and pressure in the nasal passages. That could blow the repair.
So the iGel helps prevent that.
The idea is yes. You extubate the patient while they're still reasonably deep, then immediately insert an iGel. It maintains the airway, allows you to keep ventilating if needed, but it sits above the vocal cords. It's generally much better tolerated at lighter anesthetic depths than an endotracheal tube, less stimulating. So the patient can wake up more smoothly, breathing spontaneously through the iGel without that intense coughing reflex an ETT often triggers.
That's a clever technique. A smoother transition. And then some morphine, 5 milligram IM, before leaving the OR.
Yeah, that's for postoperative analgesia. Giving some longer-acting opioid intramuscularly before they're fully awake helps ensure they have some pain relief on board when they arrive in recovery. Good pain control also helps prevent agitation or straining that could, again, stress the repair.
Okay, we've covered the WHY and the HIW pretty thoroughly. Let's crystallize the what. What are the absolute key takeaways someone listening, maybe a trainee, should really lock onto from this discussion? Intraoperatively first.
Okay, intraop essentials. Smooth intubation is paramount. Consistent, adequate muscle relaxation throughout. Don't trust the SpO2 if there's dark nail polish. Use another site. Be prepared to manage blood pressure, maybe mild hypotension if needed for surgical view, but always ensuring enough cerebral perfusion.
And postoperatively. Priorities.
Post-op, it's all about education and monitoring. The patient must understand. No nose blowing, avoid forceful coughing, no straining. Monitor closely for any signs of the leak returning clear fluid from the nose. And be super vigilant for meningitis signs. Fever, headache, stiff neck. Also, watch for signs of pneumocephalus, headache, confusion, neurological changes.
Right. And what are the common traps or pitfalls someone might fall into with these cases?
A big one is underestimating the emergence, not planning for that smooth wake-up, maybe pulling the tube too early or without a strategy like the iGel exchange, leading to coughing. Another, we hammered this, but using nitrous oxide is a critical error. And finally, poor communication. Not talking to the surgical team about the extubation plan or any specific concerns they have about the repair's fragility. That collaboration is key.
Excellent points. It really drives home that this isn't just routine anesthesia.
Not at all. It demands, a solid grasp of the pathophysiology, really careful planning, and meticulous execution from start to finish.
So summing up our deep dive on anesthesia for endoscopic CSS leak repair at the skull base,
Yeah.
it really highlights the need for thorough planning, using that multimodal approach for pain and stability, focusing intensely on smooth airway management, especially intubation and emergence, and just being meticulous. Understanding why you're doing each step is key to getting good outcomes and avoiding those potential complications.
Well said.
And remember, you can find detailed breakdowns, references, diagrams, all the things we talk about on optimalanesthesia.com starting June 2025. This has been Ink and Air. As always, stay sharp, aim for smooth, and